Hello guys, we are into the sixth discussion of our sessions on medical research fundamentals, and today our discussion will be on analytical study designs. And to start on with, let us start with a little flow chart. And first of all, if an investigator is assigning an exposure, if it is S, then it comes under an experimental study design, because we are making an exposure for the study population, and that experimental studies can be divided according to the random allocation into randomized controlled trials and non-randomized. And if there is no exposure being assigned by the investigator, then we tell it as an observational study. Under observational study, if we have a comparison group, then we call it as an analytical study designs, and if we do not have a comparison group, we call it as a descriptive study designs. About descriptive study designs, we have seen in the earlier chapters, and in the analytical study designs, we have to see what is the direction of the study. If it is from the exposure to the outcome, then we call it as a cohort study, and if it is an outcome to the exposure, we call it as a case control study. And if we are measuring both exposure and outcome at the same time, then we call it as a cross-sectional study. This cross-sectional study can be both descriptive and analytical, as we have saw in the earlier session also. So this direction of study is the main thing we have to keep in mind, because there will be a lot of confusing words like retrospective, prospective, bi-directional, such and such. But only if we are clear with the direction of the study, then we will be able to identify some study which is being done, and then conclude as whether it is a cohort study or a cross-sectional study. And this will be helpful when we are analyzing the medical literature for doing a new studies. So on the whole, exposure to outcome is cohort study, and outcome to exposure is case control study. In analytical study, if the investigator does not assign any exposure, as we saw in this flow chart, this in that time we have to make a careful measurement of the patterns of exposure and diseases in the population, and the comparison group which is being allotted will make an inference about both the exposure and the disease. And first we'll see about the cohort study. The word cohort itself means that it's a group of people sharing a same character. It is first used by the Romans, as they call the Roman soldiers marching forward in a war, called as a cohort. So, and coming on into the design of cohort studies, we can divide the population into two, that is exposed and non-exposed. And among the exposed, we have the disease positive individuals and the non-diseased individuals. And in the non-exposed population also, we have the diseased individuals and non-diseased individuals. And for the both the wings, we will find out the incidence, and that on the whole will give the relative risk of the exposure to that disease. So as we saw, the direction is from the exposure which is being followed up for a time, that studying for the outcome. Some examples of the cohort studies are the Framingham heart studies, which was done to find out the whether the risk factor of hypertension will cause the cardiovascular disease. And some example of retrospective cohort is the aniline dye and the urinary bladder cancer, in which the aniline dye workers were retrospectively studied for whether the death of them has been caused by the urinary bladder cancer or not. And coming to the type of cohort studies, as we saw earlier, when the study starts and after the study starts, if the exposure and the disease are occurring, then it is called as the prospective study design. And ambispective or bidirectional study is that the exposure would have occurred earlier, and we are starting the study after the exposure, and then we are looking upon for the outcome. That is, for example, the best example will be the COVID studies, which is being done here at present. That is, the exposure has already occurred for the study population, and we are starting the study after the exposure, and then we are seeing the outcome of how is the manifestation and what is the more risk factor and all. That is called as the bidirectional studies or ambispective cohort studies. There is something called as the retrospective studies, as we saw earlier in the example of aniline dye workers and the urinary bladder cancer. That is, both the exposure and the outcome would have occurred before the study has been started. And the elements of a cohort study includes the selection of a study population, gathering of the baseline info, and the follow-up, and then the analysis. What we have to keep in mind during the selection of the study population is that we can either do it in a general population or a subset. For example, the Framingham Heart studies, which was done in the general population, and some kind of studies on nurse health studies. That is, we are taking a subset of population. That is a subset called as the nurse population. So that we can do like that. And also we can select special exposure cohorts. For example, in occupational groups, like we cannot for example, in aniline dye workers, we cannot take all the workers, because there is workers ranging from both the managing director to the base level worker. So we have to take that special exposure cohorts, that is those who are working in exposure to the aniline dye. That kind of special exposure cohorts also we can study. And then gathering the baseline info is that we have to take a valid assessment of the exposure status of the members of the cohort. We have to first get a good identification data, then we have to exclude those with disease at the baseline, that is at the start of the study, and we have to properly identify the at-risk individuals and obtain the data on the covariables, that is like other variable exposures which will also interfere with the exposure which we are going to study. And then we have to have a good choice of the comparison group. For example, we can take both internal comparison group, that is the unexposed people in that same population, or external comparison group, that is somewhere outside that population, but somewhat similar to that exposure which we are studying. That is, when internal comparison group is not available, or for example, the observed number of bladder cancer deaths in aniline dye industry compared with the expected ones, that is some other dye industry workers, like that. And then we have to have a good follow-up of uniform and complete follow-up of all the cohort members irrespective of the exposure and unexposure groups. And we have to have a complete ascertainment of the exposure and outcome, and then we have to have a standardized diagnosis of the outcome events to make it a uniform study. Now coming upon to the term called as relative risk, this is a 2x2 table, as we all would have been familiar with this in our third year of MBBS. That is, we can have the exposed and unexposed groups and divide them as disease positive and disease negative, and we usually, for our ease of calculation, we name them A, B and C, D. And as we saw earlier, the incidence of disease in the exposed individuals is that of A divided by A plus B. So like for a quick calculation, you remember the arrow direction of that arrow which is marked in that notes. So it is like A by A plus B, and the incidence of disease in unexposed will be C by C plus D. And when you take a ratio of these two, we have the relative risk. And if this value of relative risk is equal to 1, that is the numerator and denominator is the same. So we can conclude that the exposure is not associated with the disease. And if it is more than 1, then the exposure will be positively associated with the disease. And if it is less than 1, then the exposure will be negatively associated with the disease. That's all about and now we will see some of the advantages and disadvantages of this cohort study. This cohort study helps us to calculate the incidence, and then we can study multiple outcomes for a given exposure. Like, you should not get confused of this term, like multiple exposure for single disease and multiple disease for a single exposure. Just remember the direction of the study. Like, cohort study is for exposure to outcome. So we are taking a single exposure and we are studying an outcome. So that outcome can be 1 or 2 or more. So that is, cohort study is helpful for finding out multiple outcomes from a given exposure. And case control study is we are doing from outcome to exposure. So for a single disease, we can find out 1 or 2 or more exposure. So a case control study will be helpful for finding out a multiple exposure of a single outcome. That we should be clear. And coming here, in the cohort study, we can also find the temporal sequence of the outcomes, and this is good for a rare exposure, whereas the case control study is good for a rare outcome. And This has certain disadvantages, like it includes more number of subjects, more time and expensive and time consuming, and it cannot be used for rare diseases because we are studying from an exposure. So we cannot say whether the outcome we are getting will be rare or not. That for that we have to include more and more number of subjects, which is practically not possible. So and one more thing is that we cannot study for diseases with long latency, and there will be differential laws of follow up that will eventually lead to the introducer bias, because the introducer will get tired of following up, or he'll be like tired of searching the loss of follow up participants, and that causes the introducer bias in the cohort study. Coming upon to the case control study, here our direction will be from outcome to exposure, and so we'll start with the outcome, that is the disease. So in the disease we'll divide as cases and controls, that is case is diseased and controls is non-diseased, and each among them we'll divide as exposed and non-exposed in them, and among the two wings we will find out the exposure odds is nothing but the probability, the exposure probability in the cases and the exposure probability in the controls, and from these two exposure odds we will calculate the odds ratio. The elements of case control study, actually this would be a case control study, it is written wrongly. The elements of case control study includes selection of cases, selection of controls, info of the exposure, and the analysis. For selection of cases, we have to see whether all the people of the source population who develop the disease of interest, we have to identify them properly, and the sample of cases should be independent of the exposure which we are studying, and there should be clear definition of the outcome which is being studied, so only we can divide them as cases and controls. And we have to see, we have to be clear whether we are including both prevalent and incidence cases, or we are taking into only the prevalent cases. For example, in the prevalent cases there will be increased survival with the disease than due to the development of the disease. So we have to decide whether we are taking the prevalent cases or only the incidence cases, because and one more thing is that the prevalent cases will increase the money and increase the time. So then we have to see whether where we are selecting the cases, that is whether we are taking from a hospital based population or a general population. Like for hospital based population means it will be easy to find out the cases, and that will be represent severe cases also. But when we are taking from the population, one advantage is that there is no bias by factors or that bring a patient to the particular hospital and all. And regarding selection of controls, the controls must be true representatives of the exposure in the source of population of cases, that is from the same population we have to choose both the cases and controls, and the selected controls should also be independent of the exposure status. And sources of the controls can also be population based, healthcare based, and case based. Like population based from the general population, healthcare based, that is people with other diseases, or case based matlab friends or some neighborhood. And a collecting of good data on exposure should have in mind of the objective, the accuracy, and the precision. And like objectively, that is it should reproduce the exposure measurement, and accurate is that the info should be as close as possible to the effect of the exposure, and precision is that the quality management that in the exposure measurement. Then this is the 2x2 table for the cases and controls, that is in the row side we will have the exposure and unexposed population, and then we have the cases and controls, and we mark it A, B, C, D. And exposure odds in cases will be like, here also we have to remember the direction of the arrow, that is from above to down, that is A by C is the exposure odds in cases, and B by D is exposure odds in controls. When we divide these two, we get the odds ratio, that is AD by BC. Similarly, like the relative risk, the odds ratio, we have to see whether it is equal to 1, more than 1, or less than 1, and the same inference of the relative risk will also apply for the odds ratio. And some of the advantages and disadvantages of case control studies is that it is used for some rare outcomes and for outcomes with long latency, and it is quick to conduct, and it is inexpensive, and few subjects are enough, and multiple exposure or the risk factors can be studied. Disadvantages are that it leads to recall bias, and selection of appropriate comparison groups may be difficult in these, and the rate of disease in exposed and unexposed individuals cannot be determined properly. That's all with our sixth discussion on the analytical study designs, and our next discussion will be on experimental study designs. We will be talking about the randomized and non-randomized clinical trials in that session. Stay tuned. Thank you for your support. Keep supporting us.